welcome. It's lovely to see you all this afternoon. Thank you for joining. My name's Katie Swinhoe. I work for the long-term conditions and personalisation team within the ICB. I just want to say, first of all, I know it's a lunchtime, and obviously we appreciate that some of you have finished clinics or you've been working in meetings and joining. You're very welcome to keep your camera on. We don't mind at all if anybody's having any lunch or a drink or a cup of tea. So just make yourself comfortable, or as comfortable as possible, for the next hour. We are here today for our third AF Way webinar. My job today is to chair, so I'm going to start the presentation for you and just do a little bit of general housekeeping, introducing people, and we'll ask you to introduce yourselves as well. So can I ask Laura if you can tell me if you can see the current slide?
I can. Yes.
Lovely. Thank you very much. Okay, so like I mentioned, we're here today for the AF Way third webinar, which is for the DOAC AF Tool. Today we're going to look at some practical guidance, and we're going to have a question and answer session at the end, so hopefully this should be quite interactive. We've got 3 people joining us for training today, so Mark Donnelly, Wendy Sunter and Catherine Sterling. They are our pharmacy technicians and consultant pharmacists in anticoagulation and thrombosis. They have a wealth of experience, so please use them as much as possible for the next hour. I am the project manager for the AF Way project, and I'm also joined by Laura Williams, who will kindly drop in lots of information in the chat function for you today. So you will have probably read on the information that we sent out advertising the webinars that we've received funding from Giaci Sanco. We're working in partnership with the Health Innovation Yorkshire and Humber and the ICB are together looking to deliver this project between now and probably the beginning of autumn. The project itself is focusing on detecting, protecting and perfecting the treatment for those that can benefit from anticoagulation treatment. You should have received in some of the information details about the webinars that we've been running. So this is the third webinar. The other 2 are recorded and available on our web pages, and we'll share them all with you after the session. We're also running a virtual AF service, some online resources, additional e-learning, the opportunity for face-to-face training, and we've also developed some individual DOAC dosing tool, short mini training videos and user guides. We're looking to develop some frequently asked questions, and we're also taking on board any feedback for any future training that any of the attendants are telling us about within the evaluation. You'll be sent information about all of this after the session. But like I said, if there's any questions throughout about what the AF Way project includes, please drop them into the chat and we can answer those as well as questions that are relevant for the content today. So a little bit of housekeeping. There's quite a few of us coming, which is great. We'll just ask you if you don't mind introducing yourself within the chat function. So who you are, where you work, what your role is. If you can remain muted just while some of the presenters are speaking, but please keep your camera on. We will have a question and answer session at the end, which is part of the focus of today. So please feel free to either speak verbally at that time, put your hand up, or ask a question in the chat and we'll answer those. I will probably interrupt the presenters at some point just to let them know about timings and how long we've got left, just to make sure that any questions that you've got are all included and answered. If anybody's not got any further questions, I'm going to hand over to Mark and he's going to just talk you through some of the learning outcomes for the session today. Thank you.
Thank you, Katie. I'm just going to quickly go through the learning outcomes. So at the end of the session, we want you to, we're going to let you know where to find the DOAC AF Tool and videos. I'm not going to actually go through how to run the data. I've done, as Katie said, done short videos on downloading the data, adding the data to the tool and how to use the tool. And then there's also instructions actually in the DOAC AF Tool Excel sheet. We're going to go through how the DOAC AF Tool works, how to update the sheet with missing weights of serum creatinine, how to filter and identify over and under dosing, and monitor and show if monitoring is up to date, and how data can be used to calculate dosing for an alternative DOAC. Next slide, please. So the tool was developed during an audit on DOAC dosing by the in AF by the pharmacy technician team in Leeds, and the following data is retrieved from the clinical system. Next slide, please. So the DOAC AF tool enables a quick audit of the DOAC dosing in AF, identifies which patients need to be reviewed for dosing, and identifies any gaps in monitoring. This is much quicker than it can be done. The data is run very quickly and saves a lot of time for staff and improves the outcomes for patients. So next slide, please. So this slide is showing how the correct dosing of how the dosing of DOACs was improved over time in 2022 in Leeds, where March 22 is the baseline data, and we finished recording those accuracies in January 23, and in Leeds those percentages have been maintained. So the baseline data we've got now is pretty much the same as how it ended in January 23. So it does show how it's how well it's worked. Thanks. On to the next slide, please. So this just signposting you to how to run the data. So if you there's a link there to the AFWay website. If you go to that website, you'll find some instructional videos. The videos cover how to run the data in System 1 and EMIS, how to copy the data into the tool, how to use the tool, and then the DOAC AF tool, as I said before, also contains instructions for both System 1 and EMIS, along with notes on using the tool. Thanks. Next slide, please. So this screenshot shows you part of the DOAC AF tool. The data in blue is the data that's been copied in. So missing some of the columns there. That data in blue is what's copied in, and then the section to the right is what's been calculated. So this is showing the DOAC page for a Pixiban for AF. So there's 4 risk factors there. So any risk factor is highlighted in red. So you can see there's a patient that's 81 years old, that's highlighted in red. Any patient that was under 60 kilograms would also be highlighted in red. You can see here that there's quite a lot of, there's the first column where there's a lot of unable to calculate messages coming across there. And that's because we've got no weight or serum creatinine. If you can go back to the record and find a serum creatinine that for some reason is not pulled through with the read coding, then this can be manually entered onto the sheet, and it will automatically update the values there, so you can then check if everything's if the dose is correct and everything's working correctly. So also sorry, what I want to mention there is you can see in the weight column, in column F, if you can see it, there's a 113 question mark. So someone has entered the weight as query 113 kilograms. Excel won't recognize a question mark, so it will not pick it up and be able to work things out. So you can see in the weight risk factor column, the second column with yellow at the top, it's showing value. Again, if you were to confirm that weight is 113 kilograms, and enter that into that column, it will automatically update all the rest of those values on that row for that patient. So we've gone to the next slide, please. So I've already talked about the different risk factors, and again, we're looking at a list here for Pixiban patients again. So this is showing how you can visually see where the dose would be reduced. So the second line there, patient's 80 and serum creatinine is 146. I think that's read. That theoretical dose there, the calculated dose is 2.5 milligrams because of those 2 risk factors, and the prescribed dose is 2.5 milligrams. So that is correct. So So the next column is saying dose correct as SPC, as per SPC, yes. Whereas if we go down to line 6, we've got a patient who 81, 58 kilograms. So again, 2 risk factors. The calculated dose is 2.5 milligrams. However, the patient is actually getting prescribed 5 milligrams. So therefore the dose is incorrect. So it just shows how you can easily see where the doses, what the doses should be and where the doses are incorrect. And then each column has a filter on it. So if you just want to look at patients who are overdosed, you could tick the filter on column V and see all the ones that are overdosed, or underdosed, tick the filter on U, find all the ones that are underdosed. So it's very easy to sort the data out. Okay, so the next slide, please. So the monitoring is 6 or 12 monthly based on creatinine clearance, and the tool automatically works out whether it should be 12 months or 6 months. And that's shown in this column here, 6 or 12 monthly monitoring. And then the next column then tells you whether that monitoring is in date or not. If you are then unsure if monitoring is not in date, then you can look back at the data that you've inputted under the blue headers and see which one or more of those bits of monitoring is out of date to identify where the issue is. So going to the next slide, please. So this is showing the rivaroxaban sheet, and for rivaroxaban there's only one risk factor, which is creatinine clearance. What I'm just showing here is that we've got some data here for patients who are not on not getting prescribed rivaroxaban for atrial fibrillation, because one of these is on 2.5 milligrams, another one's on 10 milligrams. The data is checking people on a DOAC with AF, but there may be instances where people are dual coded or the coding's incorrectly, and this is just showing that. So so it's showing that the first patient is prescribed 2.5 milligram rivaroxaban. That's not a dose in AF, so it can't calculate whether it's correct or not, because it's a dose not used in AF, and the same goes for the rivaroxaban 10. Works in the same way as the apixaban sheet, but like I say, just picking up these non-AF doses. So if going to the next slide, please. Yeah. So this here is showing you all the different columns of data that are pulled in for each drug. This example is showing you edoxaban and the columns of data that are coming in there. I just blanked out the surgery names there. So for each DOAC, the data is all the same. The columns of data are all the same, with the exception of this fourth column, which is the drug prescribed dose. So in this case, it's edoxaban, but it would be apixaban for apixaban, rivaroxaban for rivaroxaban. But if you potentially wanted to look at, say, these 5 patients to see if what potential dose there would be on apixaban, it's possible to copy those 5 rows of data, that 5 bit of section of data, and then paste it then into the apixaban sheet to then see what doses they would be on apixaban or another drug, because as I say, the data is all the same. If we just go to the next slide, please. So these 5 lines of data are the same bits of data that were copied from the edoxaban sheet, and they're now working out the risk factors for apixaban as they would, and they're actually working out that the patient should be on 5 milligrams of apixaban rather than the 30 milligrams of edoxaban that they're on. So this column here is showing the edoxaban that they're on. They're on edoxaban because they are on edoxaban and not apixaban. It can't then work out whether the dose is correct as SPC, because it's all based on them being on that drug. But it's a way to check what potential dose they could be on. And I think I I was talking to Wendy about this yesterday, and I think wondering if Wendy wants to come in there about that function really.
Sorry, Mark, I couldn't get my thing off. So it was about putting the different drug in there, you mean?
Yeah. So I think it was just checking that we were saying, wasn't it, about thrombotic risk and how they how to maintain someone on the higher dose where possible. And if you wanted to explain a bit more.
Oh right,
better than I can. Yeah.
So we were sort of saying, weren't we, that if a patient was highlighted as having an incorrect dose or a correct dose, you might want to change the drug. So if they were on edoxaban 30 because of their risk factors, but they had a very high thrombotic risk, then you might want to switch them onto a different DOAC that didn't have a reduced dose. So you'd put them on the higher dose, as long as it was licensed, you know, for their risk factors. Does that make sense? So for example, if you were using a apixaban, they might not have a reduced dose because the risk factors might have said to give them 5 milligrams BD rather than with the edoxaban, it might have reduced to 30 because of the risk factors. Yeah, so
these patients say, so as I say, they were on, this was a random sample, actually, I didn't really plan it as such, but they've patients on 30 milligram of edoxaban, but when you've put that data into the apixaban sheet, it's working out they should be on 5, so they're not actually, they can stay on that higher dose rather than just, I think it'll actually go to a higher dose than what they were before, effectively. So yeah, so that's just an option that you can do there, just to save some time, and rather than getting a calculator out or putting the data back into the clinical system. So if we go back to the next sheet, sorry, go on to the next sheet, please. So I think this sheet, we're just looking at considerations about how you would really use this this tool in day-to-day running. You know, you would need clear responsibilities on who will run the data. I haven't gone through how to run the data, but it is very easy to run. They need processes in place about who would pick up those patients that are that are underdosed, overdosed, or where the monitoring is not required. You would, want to think about keeping records of patients reviewed or actioned who are maybe not dosed within SPC, so that next time the tool's run, you can go back to the list and say, we know why they're on 2.5 milligrams BD of this, or we know why they're on 60 milligrams of this, rather than the 30 milligrams, because we've made a record of it. You'd consider how you're going to flag on the clinical system where all the monitoring is required, and close that loop out to get that done and timely. Also consider using group meetings, huddles to formulate plans on increasing patient engagement, and the risks along with that, the risk of withholding medication or the lack of review. So that's most of the things from me, I think. So go into the next slide. You're on mute, Katie.
Thank you, Mark. So we just want to open it up at this stage to ask if anybody has any questions. So things to consider are, has anybody used the tool already, and have you had any experience of it that's been positive or negative, or any questions that you want to ask Mark whilst he's here? And for those that haven't used it and will be considering using it after the webinar, is there anything specifically that you wanted to ask Matt now that might help you prep for it, or can you anticipate any questions that colleagues that might be using it that they may have? So I suppose those are my questions to everybody, to start a bit of a conversation about has anybody used it, and if you haven't, can you anticipate any questions that you might have? I mean, it's an Excel based tool. So that's one thing for people that have or haven't used Excel in the past. And I will say that the short videos that Mark has produced that are on our YouTube pages and on the AF Way web pages, they're short, they're sweet, and they do run through some of the practicalities of using Excel and which buttons to click and where. So they are very user friendly. But just to ask if anybody's got any questions at this stage.
Mark, there is a question in the chat for you from Tahir.
Yes,
have you read it? Okay.
Yeah, so Tahir is asking for everyone's benefit, are these reports in System 1 or do they come from the DOAC tool after completing individually in each record? So basically the process is the search is built in System 1. There's search built to identify patients on a DOAC with AF. Then you run that search, identify those patients, and then you use a report output, which then pulls out those columns of data, and then you export that and paste that into the Excel sheet. So it sounds a bit complicated, but it runs very quickly and it's very, very easy to run. So what you were seeing before, what I was showing before those screenshots was a screenshot of the Excel tool of the data that's been pulled from the clinical systems, because it's System 1 and EMIS, into the Excel, and then those were those columns with a blue header, and the rest was all calculations that Excel have worked out based on that information that's been put in. So hopefully that answers your question to here. If not, then please come back and let me know. Another benefit which I forgot to ask was which I forgot to mention was with the once you have highlighted, let's say 5-10 patients that you want to review again that may be overdosed, underdosed, or you want to check on the monitoring, for example, as well. You could use the filters, identify those patients. They could be copied into Excel and then import back into System 1 or EMIS. In System 1, you could be using as a waiting list. In EMIS, it would be a report of a report list of the patients within that group, and then you could name those groups and then follow on your actions from there. And so I can go on, I can explain that in more detail should anyone need some more help, or it depends how many patients there are really. But it just keeps it up, brings it back into the clinical system, so you're not working off an Excel sheet.
Okay. Mark, well, I have a question actually, Mark, that people might be wondering about, and I suppose it's for you, Wendy and Catherine, is when the tool's used practically, you mentioned some of the practical considerations. Could you give any examples of how a practice how frequently they might run it, and or share sort of any feedback that you've had from the users in Leeds about how successful it's been for them?
Yeah, I mean, you can see from the graph that I showed before the massive improvement in the number of percentage of correct doses from Leeds, and I think the biggest jump was for edoxaban, because we were doing active switch. So I think people were using the tool to check the dosing. So so I think that's why the edoxaban had the biggest increase in improvement, because of the tool was being used. I think going back to your other question about when to use it, I think it should be used at least annually. The more you use it, the better. If it were every month, then, because it doesn't take long to run, very, very quick to run. But if it was used annually during the medication reviews for the DOAC, that would save a lot of time and make sure that the patient was on the correct dose at least annually. But I'd say the more the better, really.
Okay. I think, Katie, I think what was discussed yesterday, some people have used certain groups of staff to get the project off the ground. So I think if you've got a trainee pharmacist or a lead technician or something like that, they do the data side of it, and then it's a great way to go through a huge amount of data to filter it out to see what you need to do clinically, and then, you know, it can then be passed on to others who would review the clinical situation. And I think that's worked really well in Leeds, you were saying, Mark, yesterday.
Yeah, I mean, you know, you might have in a practice, you might have hundreds of patients that are on, let's say, apixaban. You might some of the practices in Leeds have hundreds of patients on just like one drug, apixaban, but edoxaban and rivaroxaban as well. But the ability to be able to review those hundreds of patients within minutes, because it's literally do the searches, pull the data out, and it's within minutes to check whether the dose is correct or not. There'll only be a small amount then that you need to then follow up. Either the dose is incorrect, or the monitoring needs doing. Rather than having to look at every single patient, you can just run the data and you say, oh, well, we can push all those to one side now. There's 85% of them, 90%, because they're all fine. It's just this 10% or 5% or whatever, how many's left. So it concentrates the efforts a lot easier and prioritize what work needs doing rather than manually going through everyone. So I was recently speaking to someone in Wales, and they've been made aware of this tool, and they're saying they're doing every review is manually done, which is hugely time consuming. This will pull out the data, check everything within minutes, and then, like I say, then you've got a small list of people you need to work through rather than the hundreds that you started with.
And I think when you did the baseline data as well, Mark, have you seen that? I know they've been using it in Leeds and they've seen vast improvements, but for the other areas in West Yorkshire, they're similar to what Leeds was previous to that. Is that right? So
that's right.
So
Thanks, Wendy.
There's a huge sort of opportunity really, and an easy win to get those numbers up.
Yeah, so that's right. So going back to that line graph which I shared before, I think edoxaban in Leeds was in March 2022. There we are. Yeah. So that was 85% and then dipped down to 84% in July. But then within by October we're then up to 92%. So, and I just say some of the other areas in Leeds are around the same starting point. So we've shown that it can be done. The data there shows that it can be done. So it may seem an insurmountable task to go from 85, 86% up to 92, 93%, but we've shown we've done it in Leeds. So I think it's just having the acceptance that it will work and using the tool. I'm sure anyone that uses the tool, I hope anyone who uses the tool will be impressed by it and see how much time it saves, how it can improve the dosing. So yeah, but I'm happy to, as Kate has said before, I'm happy to come out and go through running the searches and reviewing the data, supporting people using the tool. Again, importing the patients back into the clinical system to do some further work once you've identified those people that need that that extra work doing. So I'm happy to do that with anyone that's requesting it.
That's brilliant. I'll mention there, Mark, whilst you just mentioned about the face-to-face training, we do have, it's limited capacity, but we do have some capacity to come out to practice and to PCNs if there's a group in whatever formation, and that's Mark, Catherine and Wendy to provide additional support. So whether that's to include information that was discussed in the first two webinars, whether it's to focus specifically on one area of AF treatment, or whether it's to look specifically at using the DOAC tool, especially if you've not used it before and you want to implement it and have a practice with the tool and use Mark whilst he's there. That's possible at the moment for us to book and schedule those in. So I can send out a link when I send out the follow-up email evaluation data and everything else. And if you're interested, it is based on a first come first serve basis. Mark mentioned, and you can see on here, they've got the baseline data for Leeds, but we have also got that baseline data for all the other places. So for Calderdale, Bradford, Kirklees and Wakefield. I don't know, Mark, if you wanted to share some of that within the chat and just sort of discuss what maybe it could do for those places.
We haven't got the data for Bradford as yet, just because of a problem with access. Hopefully we will have soon. I'm just trying to find my notes, and but I think generally, so Wakefield weren't that far behind what baseline Leeds are now. So in the 90s, and then Kirklees and I think Calderdale was all 86% for every. Off the top of my head, this is Calderdale were 86% off for each drug, and Kirklees were around the same, but slightly better in some places. So Sarah's asked, are these tools only used in primary care or also in secondary? This is only something that we use in primary care, because it's set up to run from the clinical systems, get the data out of the clinical systems, the EMIS system one, which aren't used in secondary care in the same way. You might be using system one, or you might use system one in hospital in LTHT, but they don't use the same way. I'll record the doses and those things. So it's just in primary care. Yeah, that's all right. So.
Another thing that that Catherine was talking about before, Catherine, was about the use of EMIS and recording with the AF anticoagulation. What was it? AF anticoagulation advisor.
Yes, so I know that EMIS has a programme called AF Anticoagulation Advisor, which is different to the AF tool. But for EMIS practices, that's something else that you can plug in your data to. So you might have found that from the tool. And then when you can set up alerts for individual patients, so you can see whether all the data is current and up to date, and whether you need to do any dose changes and things as well. So there are different things available within the different systems to support your prescribing and to ensure that monitoring is up to date as well. I mean, the obviously you've seen the results for Leeds, and you're looking at the results for the other places. We're pretty good, considering at one point they thought up to 25% of patients on DOACs were on an incorrect dose, and that was national figures. So the tool that we use in Leeds, and is obviously shared here, is similar to tools that are used in other areas of the country as well, which has improved prescribing considerably. Just to remember, those that come up with an incorrect dose, it might be that that isn't an appropriate dose for them, maybe because they're flitting between creatinine clearances of 49 and 51 mils a minute, or maybe their weight's a bit up and down and things. So it's a tool to look at people who may be on an inappropriate dose. It might be that, you know, this patient has bled on every other DOAC, and the only thing they can manage is 2.5 milligrams twice a day of apixaban, and they've had an informed discussion that that's what they should stay on because it's better than nothing. So obviously those things, you know, the tool isn't sensitive enough for that sort of thing, so that will need just documenting. And I don't know if there's anyone there's a number of people from Leeds again, which is lovely to see. I don't know if any of them want to share anything about how they use it in practice, or how they pick up those where a clinical decision or shared decision has been made with the patient that they're going to stay on that anticoagulant and that dose, even if it maybe isn't quite within the license range, because actually they understand the risks and benefits and are happy with what they're taking. I don't know if there's anyone on that can share how they manage that, and then whether that's just a note in each individual patient or something else. If you want to pop in the chat, that'd be helpful.
Thanks, Catherine. As you say, the tool is using its calculations based on SPC, so it's following the rules to the letter, kind of. So as I sort of alluded to before, if they're over 80, then that's a risk. If they're under 60 kilograms, that's a risk. So the ones, like I say, where they're hovering around, you know, the age, maybe, you know, because if someone's just gone over 18 and they've just lost a bit of weight and now they're less than 60, then that's putting them, you know, into a different dose of apixaban, for example, right? So, you know, that may be one of the reasons, but there is, like I say, it doesn't meet the nuances of what you explained. So it's a fixed dose, is it, on based on SPC.
Yeah, and it's incredibly helpful to identify those where, you know, that might have been an incorrect dose. As well, I referred a patient a few years ago who turned 80, so her dose of dabigatran should have been decreased, and she was irate because she was no different to when she was 79, and why were they just reducing her dose based on age? And we had a good discussion, and she wanted to stay on 150 milligrams twice a day of the dabigatran. She felt very happy a bit, and we discussed the risk and benefits. But you know, there's always going to be nuances. What this tool is fabulous for is to pick up everybody else, really, and to help increase the safety of this in these patients.
Yeah, that's Catherine.
Okay, I'm just going to move back to our question and answer slide. One of the objectives of today, as well as discussing the DOAC tool and asking any and answering any questions relating to that, was really to round up the third of the 3 webinars and ask really if anybody has any specific questions that relate to anything to do with AF prescribing. So the first session that we ran was about prescribing, and the second was about monitoring, and we looked at bleeding risks, and we talked through different case studies. But does anybody here today, whether you've been on one of the previous webinars or you haven't, have any questions that you want to direct to Catherine or to Wendy? And that can be anything from doing prescriptions to changing to risks, anything whilst they're here, I suppose.
Can I just come in while we're waiting for questions? You'll have heard from Katie that we're doing some sort of MDT reviews to help support maybe more complicated decisions and things. Just to say, for those in Leeds, we are still doing the separate Leeds ones that we have done for some time. So for Leeds teams, you can still do the one that we've been currently join the AF MDTs that Tara Terry sets up. Just for any confusion, this is the DTs are for the other areas. Wendy and I are happy to discuss general questions or things around difficulties with patients and anticoagulation.
Fabulous. So I'll mention it there. I'm going to skip on to this next slide. I mentioned at the beginning that we are running other items as part of the project. So there is the MDT sessions that are currently running in Leeds. We're actually opening that out to the whole of West Yorkshire as a different meeting. We're calling it the Integrated Virtual AF Service. So starting from this week, if you have any queries, any questions that relate to specific cases, we have a 1-page form that you can complete and email into us. Catherine or Wendy will provide some expert advice either by email, or if they think that you might need a chat about it, or if you specifically request a chat about it, we can book that in, and that will be within 7 days. So please take that up and share it with your colleagues. It's there to be used. We hope that it's successful, and obviously if it is and it's utilised, it's something that we hope we can keep continuing to provide for you. These webinars I've mentioned several times, they'll be available online. We are looking potentially, I've put there the 26th of June, it is to be confirmed, to run a webinar that focuses on CKD and AF. So details of that and confirmation of the date and time should follow in the next week. I'll say it again, the face-to-face training open, it can be bespoke to anything that you want it to be about. And lastly, we have some e-learning available through PresQuip. So there are 2 modules, anticoagulation and lipid modification, and we started advertising these about a week ago, and the take up has been fantastic, and the feedback from some of the people that have been using it is great. So please, that's free and it's open to everybody. So there is a link to register. It's a 2-minute form. It'll come through to me and I'll send you the log-on details. Obviously, any feedback, any issues, email me back and we can organise sorting those out. I am going to ask, just see if there's any questions that do come through. if you don't mind completing a short evaluation for today. We've been evaluating the sessions as we've gone along, and the feedback so far has been positive, and it's helped us to shape some of the services that we want to run, like the virtual surveys and the Prescript licenses and the content for today's session. So there's a QR code if you're smart with your phone. Scan it and fill it out, please. If not, I'll ask Laura if she would put the link in the chat function. And I'll leave that there and just ask if anybody else has got any other questions.
Just got another one come in the chat, Katie.
Okay.
From Mohammed, discussing a new DOAC with patients for AF. What's the best leaflet or information to send out? Who wants to answer that? I'll jump in at once.
We did put some links in, didn't we, in our first first webinar for the AF Association, and there was the tool that we discussed as well. I can't remember the specific link to them, but they were all there in the first webinar. Catherine, can you remember what specifically they were?
Not specifically, no. The AF Association has some good information on anticoagulation options. I suppose it depends which way you do it. If you're discussing with the patient what their needs are in terms of twice a day, once a day, do they eat, that sort of thing. Sometimes that narrows it down, putting the data in to look at your different dosing and things with the patient as well can help narrow it down a little bit. But yeah, the AF Association tends to be the place that we would go to for leaflets, and they usually have a sort of different options for choosing DOACs. Patient UK is also quite useful as well. Nicely written information. But and I think on there's things around the different, is it once or twice a day? Do you take it with food? That sort of thing to help people understand the differences.
I'm going to jump in as well and say that on our web pages we have got, as well as all the info I've just mentioned, some information, resources and links for patients and some for professionals as well. So those that Catherine and Wendy have just mentioned should be on there. If there's any that anybody here is already using that you might want to share, please send those through to me when I email you, and we can add those so as many sort of useful documents, leaflets, links as possible. We should be sharing them at this point.
Laura's just put in the chat, I couldn't remember what the NHSE it was called. It was atrial fibrillation decision tool. There was a bit of debate about that as to how useful it was, and I think it depends. It is sort of best practice and to use that, but I think it depends on your patient and whether they're engaged or not to use that, because it is quite long to go through that. But if you've got somebody that's really interested and they want to look at it beforehand, that's probably a nice one to use.
Can I ask a question, Wendy, for you and Catherine, about the patient engagement? I suppose one of before we ran this the seminar today, we asked people if they had any questions that they might want answering, and I think one of them that came up was how best way to phrase this, how you would best engage and communicate with a patient that isn't very great at communicating with you. Does that question make sense? So when it comes to the monitoring of them and when it comes to inviting them in, are there any examples that you've got that we might be able to share, or anybody that's attending today, about any tips that they've got about how to engage with those patients that aren't very engaging themselves?
I know we had a discussion about, I think it's very hard if you're doing everything remotely and not, from my experience with holding clinics, it's a lot easier talking to patients face to face and getting their motivations and finding out what their problems are and what their issues are with, perhaps attending for monitoring and things like that, and perhaps working with the patient. But I know certain practices perhaps have looked at reducing the amounts that they give on repeat prescriptions in order to draw the patient back in and things like that. But I know we had again that discussion about I think Emily has said previously that they had gone from, you know, 3 months to a 2 month to a 1 month, and then, you know, getting patients get across, they have to sort of engage to get their prescriptions, but then you run the risk of patients running out of medication, and that can be counterproductive as well. So it's really you know, trying to find out individually what the issues are. You might have an elderly patient who can't get into the surgery, or, you know, somebody that needs help, or they might have you know, other issues. And perhaps it might be, you know, if they're seeing another clinician for something else, you could tag into that and perhaps get the bloods done at that point. You know, so if somebody has a different issue, they might have mental health issues, and they might come in to see another practitioner, and you know, you might be able to get them weighed then, or get the bloods done at that one appointment, rather than trying to sort of ask them to come in at different times. I don't know if you've got any comments on that, Catherine.
Yeah, I think looking at different methods of communication as well. We've got, you know, I guess in the younger population more VTE, but, you know, people that are working full time and they don't want calls when they're at work. So can we text, or can they come in at different times? As Wendy said, if they're going, you know, if they're coming for another appointment. So often if they're coming into the hospital, we might put some bloods on the system so they can go to a blood room at the same time and get them done there. I know sometimes patients on warfarin and they want bloods done. Some of the pharmacists in the practices might contact us to go, oh, can you get some bloods done while they're having their INR done and things. So looking at other ways in for those patients, explaining the importance of the monitoring. I remember early on, because obviously people were saying, oh, DOACs don't need monitoring compared to warfarin, but possibly missing that bit of the second bit of the sentence, then everyone thought they didn't mean monitoring at all on a DOAC, as opposed to warfarin, where they were coming in all the time. But I think it's just explaining why we need to do it, and yeah, just looking at different ways we can get people in. They might have had a bad experience with someone taking blood. It might be that, you know, yeah, people prefer to come into the hospital, or they might have a favourite healthcare assistant at the practice. I had a patient last week that needed some bloods, and him and his wife were struggling with mobility. Well, the practice went out within 48 hours to do some bloods for us, which was super. And another patient where we had some strange blood results. They came to a hospital blood room that afternoon and got them done, and they were all lovely. So, you know, thinking about different ways to contact patients. Emails as well. Some patients we have respond much better via email than they do via their phone or their text. And some are just really difficult to get in touch with and to engage at all. I think if you get a chance to have that conversation, or asking somebody that might be seeing them anyway to have that conversation, always helps.
Thank you. Okay. So I've just leave this as the last few minutes to give anybody else the opportunity to ask any questions or any comments that you might have for either myself or Catherine, Wendy and Mark. We are extremely grateful for everybody that's attended and the feedback that you've given. Like I said, I'll share the details of hopefully the CKD and AF webinar that we plan to run in June. We appreciate that from the advertising of the webinars to the time of you attending can be relatively quite short, and your diaries are already extremely hectic. So we hope that this time of the day is suitable for people. So have we any other comments or questions within the chat, ladies and gents? No? Okay.
Not that I can see.
Lovely. Thank you, Laura.
Thanks for listening, everybody. As Katie said, thank you very much.
Yeah. Wonderful. Right. Well, I'll give you all a little bit back of your own time. Thank you very much for attending. Any feedback, please send it through, and we hope to see you at the next session.